Thank you for that formality. Don't want to be mistaken for Jeff. Thank you, everyone. My name's Ron Shumacher, and I'm with Optum Complex Population Management. And as was mentioned earlier, we are indeed part of the United Health Group family of companies. Some of you may be familiar with the Optum brand. We are the healthcare services platform under United. And you may have heard of some of the other lines of business. We have a data analytics company, pharmacy benefits management, healthcare financial services, case and disease management, consulting company. But the line of business that I'm in under Optum, which is called Complex Population Management, is a direct care delivery and care management company. And I just want to say I am also a physician. I'm an internist by training. And I've been working for this organization for about 15 years now. Prior to that, I was in private practice in an internal medicine and geriatric practice. So I think by now, we're almost at the end here. And I think you can really see some of the common threads between the presentations here. There are certainly some fundamentals that we all share in common, and we're just approaching things slightly differently. So some of my points may be redundant of what some of the other speakers have said, but I want to share with you a little bit about the approach that we're taking to a very high-risk, vulnerable population. So I think this has been said probably a number of times today. I wasn't here this morning, but clearly there's a small slice of just about every population that you look at that drives a disproportionate share of the cost. We know there's fragmentation in care. We know that much of that cost is being driven by emergency room utilization that's unnecessary or inappropriate hospitalizations, and lack of coordination of care for people who have multiple chronic conditions, as well as really adequately addressing care at the end of life. I'm not going to talk about all the different programs we have available under complex population management. I'm really going to focus on what you can see there we call Care Plus Community Program. That's a longitudinal care delivery model. It's provided largely by nurse practitioners, some physicians, who go into the home and take care of residents right where they live. You can see, though, also that we have a number of different programs that address individuals as they're transitioning out of the inpatient setting, whether they're going home or to a skilled nursing facility or to a skilled nursing facility and then home. We also address people who permanently reside in long-term care facilities, and some of you may have heard of our what has long been referred to as the EverCare clinical delivery model. That's our program. We also have palliative care and hospice services available. So I'm going to focus on Care Plus in the community, which we differentiate from Care Plus institutional because these are individuals who are living in their home. And so how do we address these individuals? Or how do we identify them? First of all, we rely on really two methods. One is through data analytics. As you've heard from some of the other speakers, we use a proprietary algorithm that allows us to identify and stratify populations based on their risk of future utilization, future healthcare costs. We know that, well, I should say that we serve in large part the managed care population. This is the traditional approach within managed care for members with medically complex, multiple chronic conditions, is really underperforms in a lot of ways. There are multiple providers. Patients are on many different medications. Oftentimes their care is very disjointed, confusing. Sometimes their care plans are absolutely contraindicated. And we know that these are individuals who aren't well served by the traditional care delivery system. Usually in-office medical care is insufficient for these folks, both in time and in quality. They don't really get the right insights. They don't develop the relationships with their physicians that are required for medically complex members. So we are here to really address the accompanying gaps in care. So Care Plus, as I mentioned, is a clinical delivery system. We work on behalf of all different types of payers, as I'll show you in a few minutes. But we provide a very proactive, preventive, maintenance care, disease education program where we teach individuals to manage their care better. But we do this with direct care providers. So our nurse practitioners are actually able to work with primary care physicians. They communicate closely with individuals' primary care physicians. And they can manage care in place in the home. That means they can write orders, they can order labs and tests, they can write prescriptions, order medications. They can engage in advanced illness discussions and really explain to people what their choices are with respect to different offerings in the healthcare system. And they really specialize in keeping people from being admitted to a hospital unnecessarily or going to the emergency room unnecessarily. They take the whole patient into consideration. So it's not just a medical model, it's a medical model that's paired with a care management system. We have a centralized care management team that supports our nurse practitioners, almost like back office support as they go into the homes and manage these individuals. I'll share with you some of our data. As you can see here, similar to what other folks have shown, what we've seen is across various markets, when you look at the baseline hospitalization rates for this high-risk population, you see very, very high rates of hospitalization in the orange bars, but the greenish color bars represent what we've been able to achieve with that same population, which is more than a 60% reduction in admissions across multiple markets. So this data happened to be from one client that we were serving who had patients in multiple markets across the country. But you can see the results tend to be very consistent and very significant. So essentially, we're providing a house call program with home visiting providers that's paired with a care management and technology company to serve high-risk individuals. This graph shows you something that we've noted as well, which is that as these individuals tend to be approaching the end of their life, you can see here that the costs are greatly reduced, especially as you get closer and closer to the end of life. The middle line that you see there are all Medicare patients, and you can see what happens to their costs as they near the end of life. They go up. But to be fair, the top bar is Medicare high-risk patients. And that line goes up even more markedly, whereas you see that with the Care Plus program, the home care managed patients, the line is much flatter, and there's a huge difference, especially as you get to that month or two prior to the end of life. So the financial value we really look at in terms of the customers that we serve, not just the patients that we serve, obviously very important, but also who is the payer who's bringing us in to actually take care of these patients. You can see here we reduce overall health costs for these medically complex members by anywhere between 42% and 52% compared to non-managed at-risk members. We reduce hospital admissions by 60%, as we showed you earlier, healthcare costs in the last 6 months of life by 61%. And what we tell our customers is there's an average return on investment anywhere from 2 to 4 to 1. So it's pretty significant. In terms of quality improvement, most of our customers are interested in having us address gaps in care. Many of our health plan customers, because again, we serve United Healthcare as a customer, but we also serve lots of other health plans around the country. And they're interested, particularly on the Medicare Advantage side, in the Medicare Advantage HEDIS and STAR ratings, because we have caregivers, providers in the home. We're really able to make a difference in terms of those quality metrics. And then, we also see that there's a very high degree of patient and family satisfaction with the program. I just wanted to make one comment about payment. As I mentioned, some of the potential payers that we work with could be health plans. And typically these are managed care plans either on the Medicare Advantage side or the managed Medicare side. Now we're seeing, obviously, in many of the states, the dual funding stream with the MME programs for dual eligible patients. And we work very well with those types of plans as well. Delegated provider groups, accountable care organizations, and one area that I think would be really important going forward would be to work directly with state and federal governments as opposed to through the health plan. We get paid in a lot of different ways. We could get paid, and probably the most common is what we would call a case rate, because we get paid on a per engaged member per month basis. That means that our customer is only paying us for the individuals that we actually engage with. But we can also get paid on a capitated basis. We can put into place a gain sharing program with quality metric goals, as well as we work with some customers taking full risk and a percentage of premium. So I think that was all I wanted to say about the Care Plus community program, and obviously at the end be open to any of your questions. Thank you.